Welcome back to The Deep Dive, the show that's really all about cutting through the noise to get you the knowledge you need fast. Today, we are strapping in for a really intense one. We're going deep into the world of emergency department management of lower limb trauma. So whether you're a practitioner looking to sharpen your protocols or just someone curious about this high-stakes environment, our mission is simple. We're going to distill the absolute critical playbook for recognition, X-ray diagnosis, and management of injuries from the hip right down to the toe.
That's it, exactly. And the sources we're pulling from today, they're basically the core curriculum for any acute trauma provider. They really hammer home the non-negotiables, and our whole deep dive today is built on, well, two fundamental truths. First, you always stabilize the patient before you stabilize the limb.
Always.
But just as important, and this is maybe the more modern piece, is the rule that you never, ever delay proper pain relief, analgesia. That immediate humane action is really where modern trauma care begins.
That's a great place to start. That idea, the urgency of pain management, is such a huge shift in thinking. It really forms the bedrock of our first section here. So let's unpack that foundation. We have to begin with what you call the golden rule of pain relief. Anyone who's seen a high-energy, lower limb injury, a femur or pelvic fracture, knows the kind of agony we're talking about.
No, it's indescribable.
And our sources make this incredibly compelling point, both ethically and practically. Pain relief has to be urgent. It has to be essential. A patient doesn't have to, earn their medication.
No, and this is a complete departure from some of those older doctrines that really governed emergency rooms for decades.
You mean the idea of masking symptoms?
Exactly. For years, there was this incorrect and frankly harmful belief that if you gave powerful pain medication, especially opioids, you might cover up the signs of a critical internal injury.
Like an acute abdomen or something.
Right, or subtle changes in their neurostatus. But modern emergency medicine has just completely thrown that out. We know now that a patient in intense pain is, well, they're non-cooperative, they're tachycardic, hypertensive.
Impossible to examine properly.
Completely. Treating that pain right away actually improves their physiological state, it builds trust, and it lets you do a much more effective and, frankly, a much more accurate secondary survey.
So if we're talking about a patient who's in agony from, say, a suspected femoral shaft fracture or maybe an unstable pelvic injury, what's the standard tool we reach for? And are there different considerations for kids versus adults?
For severe pain, the gold standard is still intravenous morphine. It's incredibly effective, you can titrate it quickly, and almost every provider is familiar with it.
Fair.
But a really key practice point, especially in adults, is the high incidence of nausea and vomiting that comes with IV opioids. So best practice is to be proactive. You should really consider giving an antiemetic, something like cyclizine, right alongside it.
And for kids, is it the same approach?
For pediatric trauma, IV morphine is absolutely the right call for severe injuries. The dosage, of course, is all weight-based, and you have to be precise. But the big thing to watch out for there is sedation.
Right.
Kids can sometimes decompensate very quickly from oversedation, so you watch them like a hawk. Interestingly, though, they don't seem to need the antiemetics as routinely. A child under 10, for example, usually won't need one, but the principle is the same. Severe pain gets treated aggressively and right away.
Which brings us into that bigger non-negotiable framework for trauma care, the ATLS sequence, Advanced Trauma Life Support. Because pain relief is the immediate compassionate act, but it has to happen inside a structure that's designed to prevent death.
Yes.
You just can't let a dramatic-looking leg injury distract you from, say, a failing circulation.
You can't. And that's what ATLS does. It imposes this disciplined, standardized, step-by-step framework. It makes sure that even in a chaotic ED, the life-threatening problems get found and managed first, every single time.
And that sequence goes from the primary survey and resuscitation,
where you find the immediate threats,
to the secondary survey, which is a detailed head-to-toe, and then on to definitive care.
That's the flow.
And that initial approach, the CBCDE approach, is often misunderstood. It's not just A for airway anymore.
No, and that's a critical update. It starts with a lowercase c for catastrophic hemorrhage control. This is absolutely number one, especially in lower limb trauma. A massive pelvic or femoral bleed can kill a patient in minutes.
So stop the bleeding first.
Before anything else. Then you move to A for airway, B for breathing, C for circulation, D for disability, your neuro assessment, and finally E for exposure, where you get them fully undressed but also prevent them from getting cold.
And with these lower limb injuries, That C for circulation is where a lot of the focus is
Yeah.
because of that massive potential for blood loss.
A huge amount of focus.
Now, if we fail in that initial resuscitation, especially in managing that hemorrhage, we risk triggering something catastrophic. Our sources call it the triad of death. Why is this triad so uniquely lethal in this context?
The triad is, it's this combination of trauma-induced coagulopathy, acidosis, and hypothermia. And it's so lethal because each part of it makes the others worse. It's a vicious downward spiral.
Okay, so walk us through that.
So you have massive hemorrhage, which is common with, say, a type C pelvic fracture. That leads to hypothermia because the patient loses blood and can't thermoregulate, especially if they're exposed on a cold table.
Right.
Then the hypothermia itself directly impairs the clotting cascade. So now they have coagulopathy, they can't form clots effectively, so they bleed more.
Which makes the hypothermia worse.
Exactly. And all that blood loss leads to poor perfusion. So the cells are starved of oxygen. They switch to anaerobic metabolism, which creates a buildup of lactic acid, and that's your acidosis.
And the acidosis also worsens the clotting.
It poisons the whole system. Once a patient is in that spiral, their survival chances just plummet. So preventing it means aggressive fluid and blood product resuscitation, rapid warming with blankets and warm B fluids, and activating the massive transfusion protocol early.
It really underscores that priority.
Yeah.
Stop the bleed before you even think about setting the bone.
100%.
So that sets the hierarchy perfectly. Once the patient is stable and hopefully more comfortable, the focus shifts to the wound itself. And this is where we get into one of the most serious injuries in orthopedics, the open or compound fracture. Just to be clear, what exactly defines an open fracture?
It's a simple definition, but with huge implications. An open fracture is any fracture where the bone break communicates with the outside world through a wound in the skin.
Well, even a tiny little puncture.
Even a tiny one. That communication means immediate bacterial contamination. The risk of deep infection, of osteomyelitis, just skyrockets.
And this is where we need a very specific language to classify these injuries, the Castillo-Anderson classification. Why is this so powerful for the team in the ED?
It's the gold standard. It's so powerful because it dictates almost everything that comes next. It tells you the antibiotic regimen, how urgently they need surgery, and it gives you a sense of the ultimate prognosis. And it's all based on the degree of soft tissue damage, which is the key predictor of infection.
Okay, so can you break that down for us?
Sure. It's basically three main types. Type I is the mildest. You've got a small wound, less than a centimeter. It's usually clean, low contamination. Think of a bone spike just barely piercing the skin from the inside.
Manageable.
Relatively. Then you have type 2. Here the wound is bigger, more than a centimeter, and you've got moderate soft tissue damage. The energy that caused the injury was higher, so the contamination risk goes up.
And then there's type 3.
Type 3 is the severe category. This means extensive soft tissue damage, high energy, high contamination. Think farm injuries, shotgun wounds, major crush injuries.
And the sources say type 3 is subdivided, and that's where the really critical decisions are made, right?
Precisely. This is the crucial part. Type 3 gets broken down based on the condition of that soft tissue envelope around the bone. So type 3 means that even though it's a bad injury, there's still enough healthy soft tissue to cover the bone after it's fixed.
Okay.
Type IV is worse. This is where you have periosteal stripping. The membrane covering the bone is torn away, and the bone itself is exposed. There's a lot of dead tissue that will need to be surgically removed.
And then there's the worst case scenario.
Then there's type I3. This is the ultimate red flag. The C stands for circulation. It's an extensive soft tissue injury plus an associated vascular injury that needs to be repaired.
So the limb's blood supply is cut off.
Exactly. A type I injury means the viability of the entire limb is hanging by a thread. That patient needs to be in an operating room, yesterday. It's a limb salvage emergency.
So a patient comes in with an open fracture, especially type 3. What are the absolute non-negotiable first steps in the ED before they head to surgery?
Analgesia and fluids, always first. Then you gently apply traction and splint the limb to stop the sharp bone ends from causing more damage. But the next two steps are systemically critical.
Okay.
Antibiotics and tetanus prophylaxis. They are mandatory and they have to be given fast. You start broad-spectrum IV antibiotics immediately. FRCEM is a classic choice to get ahead of that contamination.
Now, there was a fascinating point in our sources about a very common practice, taking wound swabs. What's the guidance there?
The guidance is very clear. Do not perform routine wound swabs in the initial assessment.
Really? Why not?
Because clinicians feel this urge to know what bug they're fighting, but in that acute setting, a superficial swab is totally unreliable. It doesn't tell you what's growing deep in the wound, and most importantly, it never changes your immediate management.
Your immediate management is based on the Gaskelo-Anderson type.
Exactly. You treat broadly based on the classification. You control the obvious bleeding with pressure, you get the antibiotics in, and you get them ready for the OR. The definitive surgical debridement and deep cultures taken in the operating room are what actually guide long-term treatment.
That rigorous, time-critical sequence, from pain relief to antibiotic prophylaxis, it sets the stage perfectly for diving into the most high-energy and hemorrhagic injuries, those of the pelvis and femur. When we start talking about pelvic ring fractures, we are immediately talking about a massive transfer of kinetic energy. The pelvis is this strong, bony ring, and when it breaks, it carries the highest risk of massive internal bleeding of any lower limb trauma.
Absolutely. Stability is everything. And Pyle's classification is the language we use to describe that stability, and it guides our resuscitation. It answers the question, do we need to close this ring down right now?
So it's categorized by increasing instability.
That's right. So you start with type A fractures. These are stable. They're both rotationally and vertically stable. A classic example would be an isolated pubic ramus fracture. The ring itself is still intact and can bear weight.
And these are often seen in the elderly, right?
Yes, and that's an important point. They are very easily missed in older patients, often from what seems like a minor fall because of underlying osteoporosis.
So on an X-ray for type A, what are we looking for?
You're looking for single fractures, like a break in the superior or inferior pubic rami without any displacement of the sacroiliac joints in the back. The management is generally non-operative. It's about analgesia, some bed rest until they can mobilize, which is usually 3 to 6 weeks, and then a lot of physical therapy.
Okay, so type A is stable, but then we move to type B, and this is where rotational forces come into play.
Correct. In a type B fracture, the pelvis is rotationally unstable, but it's still vertically stable. The classic analogy is an open book injury. Think of the pelvis opening up like a book. The anterior structures, like the pubic symphysis, are disrupted, but the strong posterior ligaments are still at least partially intact. So it won't collapse vertically, but it can swing open.
And what's the risk there?
The primary risk is ongoing, though usually more controlled, hemorrhage. As the pelvis opens, it tears the network of veins and arteries that line the inside of the ring.
And that leads us to type C. You said before, this is the emergency.
This is the big one. These are rotationally and vertically unstable.
So if there's one thing you need to remember from this section, it's type C pelvic fractures. What defines this catastrophic injury when the patient arrives?
Type C means there's a complete disruption of the pelvic ring in at least 2 places, front and back. The patient is often hemodynamically unstable, in shock, or about to be.
Why is the blood loss so massive?
Because the pelvic volume can expand dramatically. When the ring is broken, it's no longer a contained space. A patient can lose several liters of blood into their own pelvis very, very quickly. It's a massive, uncontained internal hemorrhage.
So the clinical signs are shock.
Signs of shock are paramount. A distorted pelvis, severe pain, maybe one leg looks shorter than the other. The management is immediate aggressive resuscitation. You're activating the massive transfusion protocol, and you are taking immediate steps to stabilize the ring right there in the resus bay.
What does that look like?
Usually it's applying a pelvic binder or even just a bed sheet wrapped tightly around the pelvis at the level of the greater trochanters. The goal is to act like an external clamp to close that open book and tamponade the bleeding vessels. It's a life-saving first step before they get to the OR for fixation. The mortality rate for these is still very high.
Wow. Okay, so beyond the main ring, we also have to think about the structures at the very base. The sacrum and cossagus. These usually come from a direct fall right onto your bottom. What's the single most crucial check we have to perform here?
The absolute #1 critical check is to rule out associated sacral nerve root damage. This is what separates a straightforward, painful fracture from a complex neurosurgical emergency.
And what do those nerves control?
They control everything essential down there: bowel, bladder, and sensation in the saddle area.
So what does that neurological check involve?
You have to be systematic. First, check for saddle anesthesia. Ask if they have numbness where they would sit on a saddle. That's the S2 to S5 dermatomes. Second, you need to do a rectal exam to check for decreased anal tone.
Okay.
Third, check for any lower limb weakness, specifically in the muscles controlled by those sacral nerves. And fourth, Bladder dysfunction. Are they unable to pee? Are they in acute retention?
And any one of those is a red flag.
Any positive finding means you are on the phone immediately to the neurosurgeons or the orthopedic spine team. It's an emergency. Cardiac fractures, on the other hand, are usually just a clinical diagnosis. They're miserable, but we manage them with analgesia and a ring cushion. We don't usually even x-ray them.
Okay, let's move up to the femur, the powerhouse of the leg.
Yeah.
Femoral shaft and proximal fractures are just notorious for huge fluid loss and shock. How much blood can someone actually lose into their thigh?
A closed femur fracture can easily bleed 1 to 2 liters of blood into the soft tissues of the thigh.
1 to 2 liters.
Yes, and that is absolutely enough to cause hypovolemic shock on its own, which brings us right back to preventing that triad of death.
And the presentation is different depending on the patient, right?
It is. In younger patients, it's almost always a catastrophic high-energy event. A major car crash, for example. In older osteoporotic patients, a proximal fracture, like a subtrochanteric fracture just below the hip joint, can happen from a simple fall from standing height.
But in both cases, the signs are pretty dramatic.
Oh, yeah. The leg is typically shortened, rotated outwards, and the patient is in just exquisite, unbelievable pain.
And that pain is the key challenge. We talked about IV morphine. But for an injury this painful, the sources say regional anesthesia is a total game changer.
It's the absolute standard of excellence. We're talking about either a femoral nerve block or, even better, a fascia iliaca compartment block or FICB.
A fascia iliaca block.
These regional blocks provide rapid, dense, and incredibly effective analgesia. The difference in the patient's experiences, it's just night and day. They go from screaming in agony to calm and manageable in minutes. It makes everything that follows, imaging, splinting, so much safer and more humane.
So tell us a bit more about that fascia iliaca block. Conceptually, why is it so powerful, and how has modern tech made it safer?
The beauty of the FICB is that you're not trying to hit a single tiny nerve. You're injecting a large volume of local anesthetic into a potential space, a plane beneath the fascia iliaca, and in that plane run the nerves that supply the entire thigh, the femoral nerve, the lateral femoral cutaneous nerve, and often you get some spread to the obturator nerve too.
So you numb the whole area with one injection.
Essentially, yes. And the huge advancement is the routine use of ultrasound guidance. While you can do it blind based on landmarks, using ultrasound is just infinitely better.
Why is that?
With ultrasound, you can see your needle tip in real time. You see the artery you need to avoid, you see the fascial plane, and you can watch the local anesthetic spread exactly where you want it to go. It means it's safer, you're not going to inject into a blood vessel, and it's far more reliable. It dramatically cuts down on how much systemic opioid the patient needs.
So once the pain is under control and their circulation is stable, what's the next step for imaging? The sources mentioned a pan-CT.
With any high-energy mechanism, which is usually the case here, you have to assume they have other injuries until you prove they don't. So the initial management includes 5-tranexamic acid TXA, which is a standard in major trauma to help stabilize clots.
Okay.
You apply gentle traction. There are special splints, like a Kendrick traction splint, that help align the bone fragments and reduce pain and further bleeding. Then, yes, imaging. A pan-CT is a CT scan that covers the head, neck, chest, abdomen, and pelvis.
And you have to add the leg to that.
You must extend the scan to include the femoral shafts. You're looking for other injuries. Did they also dislocate their hip? Did they injure their knee on the same side? You have to be systematic, or you will miss things in the chaos of a major trauma.
That systematic approach, analgesia, TXA, splinting, comprehensive imaging, that really is the definition of expert acute trauma care. All right, as we move further down the leg, tibial shaft fractures introduce a whole new level of risk, and it's all about the soft tissues, isn't it?
It really is. The tibia is the second most commonly broken long bone, but anatomically, its front surface, your shin, is only covered by a very thin layer of skin and periosteum. There's no muscle padding there.
Which means it's really prone to becoming an open fracture.
Extremely prone, and it makes it susceptible to all sorts of complications.
So for imaging, what's the non-negotiable rule?
The rule is that your x-rays must show the entire length of both the tibia and the fibula. And critically, you have to include the knee joint above and the ankle joint below.
Why is that so important?
Because associated fractures at either end of the bone are so frequently missed, you get focused on the obvious break in the middle and miss a subtle fracture at the ankle. Also, you have to remember, some fractures, like stress fractures, might be totally invisible on the first x-ray. You need a high index of suspicion.
And how does the management plan for a tibial fracture depend on its shape and stability?
It depends entirely on that. If you have what we call an undisplaced transverse fracture, so a clean break straight across, but the bone ends are still lined up nicely, you can often manage that initially with just immobilization.
In a cast?
Yes, typically a long leg POP back slab. POP is just plaster of Paris. A back slab is a half cast, which is important because it allows room for the inevitable swelling without cutting off circulation.
But what about the less stable fractures?
Well, any spiral or oblique fracture, or any fracture that's significantly displaced, is considered unstable. These still need to be immobilized, but they require immediate orthopedic referral. They'll often need to be admitted for an MUA, manipulation avert, under anesthesia to realign the bones, or more commonly, they'll go on to have a closed intramedullary nail put down the center of the bone to fix it.
What are the immediate red flags with a tibia fracture? The things that make it a limb-threatening emergency right now?
There are 3 huge ones. If you see any of these, you're calling the ortho team immediately. First, any suspected vascular injury, or the pulse is weak or absent in the foot.
Okay.
Second, any sensory deficit, numbness, tingling that suggests nerve damage. And third, and this is a big one, gross swelling.
Why is swelling such a major red flag?
Because it's the precursor to compartment syndrome. This is a true surgical emergency. The muscles in your lower leg are wrapped in these very tight, inelastic fascial sheaths or compartments.
Right.
If you get bleeding or swelling from the fracture inside one of those compartments, the pressure can build up incredibly fast. It gets so high that it chokes off the blood supply to the muscles and nerves within it.
And that tissue starts to die.
It dies, and it's irreversible. The classic sign is pain that is totally out of proportion to what you'd expect from the injury. It's often made worse by just passively stretching the muscles in the foot. If you suspect it, they need an emergency fasciotomy where they surgically slice open the fascia to release that pressure.
That's a critical link. Okay, speaking of vascular risk, let's pivot to the knee joint itself. Knee dislocation. Our sources say it's rare, but it carries a truly catastrophic risk.
It is arguably the most urgent orthopedic injury there is. A true knee dislocation, where the tibia and the femur completely lose contact, has an alarmingly high risk, up to 50%, of an associated popliteal artery injury.
50%, wow.
Yes. The artery runs right behind the joint, and the immense force it takes to dislocate a knee often stretches, tears, or dissects that artery.
So what's the immediate action?
Immediate and thorough vascular assessment. You check the distal pulses, the capillary refill, the color and temperature of the foot. You compare it to the other limb. But even if the pulses feel okay, you have to be incredibly suspicious.
So you still need more imaging.
Absolutely.
Yeah.
You need to arrange for an urgent angiography or a CT angiogram to see the vessel properly. The first step is to reduce the dislocation immediately to try and take tension off the artery, but you cannot delay that vascular workup. This is a limb salvage situation, pure and simple.
Now, patellar dislocation is much more common, thankfully. How is that managed differently?
A patellar dislocation is your classic twisting injury, maybe in sports. It's almost always lateral, so the kneecap pops out to the side. It looks very dramatic.
I bet.
But the good news is that most of them can be reduced right there in the ED. The technique is usually just to gently extend the knee while applying a bit of medial pressure to the kneecap. It often just clunks back into place.
And on what?
After you reduce it, you immobilize them, usually in an above-knee POP back slab, holding the knee in full extension. They'll wear that for 2 or 3 weeks, and then they need a really good course of physiotherapy focused on strengthening the quadriceps muscles to prevent it from happening again.
Let's talk about the ligaments, the cruciates ACL and PCL, and the collaterals, MCL and LCL. How do we sort those out in the acute setting?
Ligament injuries are mostly a clinical diagnosis. It's about the mechanism of injury, where the tenderness is, and then stress testing the knee. If a patient tells you they felt a sudden pop, you're already thinking ligament tear.
Okay.
For the collaterals on the sides, you apply varus and valgus stress to see if the joint gaps open abnormally. For the cruciates inside the joint, you have tests like the Lachman test or the drawer test.
Our sources highlighted a specific sign for the PCL, the posterior cruciate ligament.
Yes, the posterior sag sign. This is a great one to remember. If you have the patient lie on their back and bend the injured knee to 90 degrees, you look at it from the side. If the PCL is torn, the tibia can just sag backwards under the influence of gravity. It looks like it's dropped back compared to the femur.
And the treatment for these depends on the grade of the injury.
Exactly. Grade 1 and 2 injuries, where it's just a sprain or a partial tear with mild laxity, are usually treated conservatively. We use the RICE principles. rest, ice, compression, elevation, plus analgesia and early physio. But a grade 3 injury, which is a complete rupture with significant instability, that needs an urgent orthopedic referral. They may need surgical reconstruction.
Finally, within the knee joint, we have to talk about the dreaded locked knee.
A locked knee is another critical sign that you can't ignore. It means the patient physically cannot fully extend or flex their joint. It's stuck.
What causes that?
Usually it's a mechanical block. A piece of torn meniscus, a loose piece of cartilage, or something called osteochondritis dissecans, where a fragment of bone and cartilage breaks off. It's like a doorstop jamming the joint mechanism.
And the action plan for that?
Any patient with a true acutely locked knee needs an immediate orthopedic referral. They need to get that blockage sorted out to restore mobility and prevent the joint from getting chewed up long term.
That really covers the huge range of complexities around the knee and tibia. Let's move further down the leg.
Okay, moving into the distal extremities, ankle trauma is just the bread and butter of any emergency department. It can be anything from a simple sprain to a fracture that just destroys the joint surface.
That's where the volume is, for sure. The vast majority of ankle injuries are simple lateral ligament sprains. It's that classic inversion injury where you roll your ankle and you damage the ligaments on the outside, usually the ATFL and the CFL.
And the management for that is ICE. For basic sprains, yes. Rest, ice, compression, elevation. For a mild grade CES or 2 sprain, where the ligament is just stretched or partially torn, you might put them in a functional brace or a walking boot. But if it's a recurrent problem or a really bad grade 3 sprain with a lot of instability, that needs an orthopedic referral because they sometimes need surgical repair.
Now, when we shift to ankle fractures, how do we quickly decide who can go home in a cast and who needs to be admitted?
It's all about the stability of the ankle mortise. The ankle joint is a very precise hinge, and it needs that stable bony ring formed by the malleoli to work properly.
So if only one bone is broken.
An undisplaced fracture of just the lateral malleolus, the bone on the outside, can often be managed conservatively. You put them in a below-knee plaster cast, a BKPOP, and arrange for outpatient follow-up.
But if more is broken?
As soon as you involve both sides of the joint, you've lost stability. So a bimalleolar fracture or a trimalleolar fracture, which also involves a piece off the back of the tibia, or really any displaced fracture where the joint surfaces don't line up perfectly, that patient needs to be admitted.
And they'll need surgery.
They'll need either a manipulation under anesthesia to get it lined up, or, more often, they'll need an ORI F open reduction and internal fixation, where a surgeon puts plates and screws in to restore that perfect alignment. If you leave that joint even a millimeter out of place, you are guaranteeing they will develop arthritis.
We can't talk about complex ankle trauma without mentioning pylon fractures. The name itself just sounds destructive.
It's a devastating injury. A pylon fracture is from a high-energy axial load. Think of a fall from a height where the patient lands on their feet. The body's weight drives the talus, the main ankle bone, right up into the bottom of the tibia, shattering the joint surface.
What are the complications?
Massive soft tissue swelling, a very high risk of long-term disability, chronic pain, and arthritis. They're very complex injuries that always need a CT scan to really understand the damage, and they always require admission under a specialist orthopedic team.
And a similar mechanism affects the heel bone, the calcaneus.
Yes, calcaneal fractures are the classic result of a fall from height landing on your heels. The force goes straight through the heel bone. They present with huge swelling, bruising, and a total inability to bear weight.
And x-rays aren't enough for these either.
Plain x-rays are often not sufficient. You need a CT scan to see how badly the subtalar joint, the joint just below the ankle, is involved. Because of the high risk of functional limitation, they need immediate ortho referral. And a key tip, whenever you see a calcaneal fracture, you must check the spine.
For other axial load injuries.
Exactly. You have to look for compression fractures in the thoracic and lumbar spine from the same impact force.
Okay, let's switch to soft tissues, the Achilles tendon. How do we quickly and reliably diagnose an acute rupture in the ED?
An Achilles rupture is a clinical diagnosis. The patient will often tell you they felt a sudden, sharp pain, like they were kicked or hit with a baseball bat in the back of the leg.
And there's a specific test for it.
Yes, the Simmons test or the calf squeeze test. It's very reliable. You have the patient lie face down with their feet hanging off the end of the bed. You squeeze the calf muscle belly. In a normal person, the foot will passively plantar flex, meaning it points downward.
But if the tendon is ruptured,
that connection is broken. You squeeze the calf and you get little or no movement of the foot. That's a positive Simmons test, and it's pretty much diagnostic.
And once you've made that diagnosis, what's the initial safest management?
Immediate immobilization. You put them in a non-weight-bearing below-knee cast. And critically, you have to cast them with their ankle in significant plantar flexion with the foot pointed down.
Why that position?
Because that position brings the two torn ends of the tendon as close together as possible. It minimizes the gap and gives it the best chance to heal, whether they end up having surgery or being managed in a cast. An ultrasound can help confirm how big the gap is.
And how do we distinguish that acute rupture from the much more common overuse injury, Achilles tendinopathy?
Achilles tendinopathy is an inflammatory overuse injury. The pain comes on gradually. It's worse with activity. They'll have tenderness right on the tendon, but the key is that the tendon is still intact. So the Simmons test will be normal. You squeeze their calf and the foot will still plantar flex. That's the key differentiator.
Moving into the midfoot, there's one critical, often missed injury that requires a really high level of suspicion, the Lisfranc injury.
Ah, the Lisfranc. It's infamous because it's so easy to miss on plain x-rays, especially if the displacement is subtle. It's a disruption of the joint complex where the metatarsal bones meet the midfoot.
Why is missing it so bad?
Because it destabilizes the entire arch of the foot. If you miss it, the patient can go on to develop a severe flat foot deformity, instability, and chronic debilitating arthritis.
So what's the action plan if you suspect it?
If you have a high clinical suspicion, they have pain right over that part of the foot, they can't bear weight, maybe there's a subtle widening on the x-ray, you have to get more advanced imaging, a CT or an MRI, and it needs an urgent orthopedic referral for fixation.
Finally, let's wrap up with the smallest parts. Toes and their compound wounds.
Toe injuries are all about good pain control and precision. For a dislocation, which can look awful, the process is simple. Give them a digital block with local anesthetic at the base of the toe, reduce it, get an x-ray to confirm it's back in place, and then just buddy strap it to the toe next to it.
And what about compound toe injuries? Do the same big principles about antibiotics apply to these small bones?
Absolutely. The principle of contamination is the same regardless of the bone size. You have to do a thorough wound cleaning and debridement under a good digital block. You must give them prophylactic antibiotics and make sure their tetanus shot is up to date. While many can go home with advice to elevate it, any severe compound injury still needs an orthopedic review.
That brings us through the whole spectrum, from the life-threatening instability of a type C pelvis all the way down to a simple toe. The sheer variety of management, from simple bed rest to massive immediate surgery, is really striking. Hashtag tag outro. So what does this all really mean for you, the learner? Our deep dive today has, I think, really mapped out the hierarchy of care. We've established that the journey always starts with pain relief and overall patient stabilization, that CACDE framework, making sure you deal with the life threats first.
And we've seen how the location and the mechanism, a low-energy fall versus a high-energy crush injury, completely dictates the immediate plan. You have to be able to tell the difference between a stable injury, like a type A pelvic fracture that can be managed conservatively, and the unstable limb or life-threatening emergencies.
Like the type C pelvis.
Like the type C pelvis, or displaced ankle fractures, or that catastrophic vascular risk that comes with a knee dislocation.
So let's just reiterate those critical red flags, the things that mean you need to get a senior surgeon involved immediately.
Okay, here are the 4 things you have to recognize instantly. Number 1, vascular compromise. Poor pulses or perfusion distal to an injury, especially with a knee dislocation or a Gustilo-Anderson type IIC fracture. Number 2, risk of compartment syndrome. That's gross swelling, pain out of proportion, or any new sensory deficit. That needs immediate surgical pressure release. Number 3, hemodynamic instability, shock that you can't correct quickly, usually from a massive pelvic bleed. And number 4, injuries that need immediate reduction. That includes knee dislocations to save the blood supply or any grossly displaced fracture of the tibia or ankle that's clearly going to need an operation to restore function.
That's an incredibly clear set of action points.
Yeah.
And here's where we want to leave you with a final thought to mull over. We spent a good amount of time on the fascia iliaca block for femoral fractures. That one single targeted intervention can take a patient from unimaginable agony to controlled pain in just a few minutes.
It really can't.
And it facilitates every single step of care that comes after.
Which really raises a powerful question about how medicine evolves. What other old school doctrines, like that once common practice of delaying analgesia for fear of masking symptoms, are being completely overturned by modern, advanced, and more compassionate standards of care? The integration of these specialized anesthetic techniques right into the initial trauma bay fundamentally changes both the prognosis and the ethics of how we deliver acute care.
Find the fear, find the pain, and treat it aggressively. That really is the modern trauma ethos. Thank you for joining us on the deep dive. We'll see you next time.